Hi, students. I'm going to talk to you about some high-risk issues for your next exam. So I'll be discussing diabetes, substance use and abuse, and then postpartum depression and such. Some of this might be overlap from the other instructors, but it's still good to repeat it. So Adriana is let me share my screen, I'm sorry. Okay, that's better, huh? Okay, so we're going to talk about a client. Her name is Adriana. She is 32 years old. She's married, and she's a Hispanic woman with one child already. She presents to our office today with her third pregnancy. So during her first pregnancy, she was 28, and she developed gestational diabetes and had to begin some glyburide to control her blood sugar during that pregnancy. Subsequently, she delivered a preterm neonate at 36 weeks. Okay. And then when she turned 30, she was diagnosed with type 2 diabetes and then had a second pregnancy that she delivered at 33 weeks, and it was a stillborn. Okay. So today she comes in with her third pregnancy, and she's 32 years old. This is not an uncommon scenario with a woman that's Hispanic. The Hispanic population are at risk for diabetes. So she probably has a family history of diabetes. So when she was her first pregnancy, she had gestational. So, and we actually had to treat her with medication. And then because of that, she is at risk later in life to develop type 2 diabetes. And that's exactly what happened to her. And she was diagnosed just 2 years after her first pregnancy with type 2 and had another baby. And maybe her glucose wasn't well controlled during a pregnancy, and she had a stillborn baby. Okay. So she's had a lot going on in her life at this age already. So now she comes to us at 32 years old. And you can imagine the anxiety, or at least the stress, the concern that she has. She's a diabetic. She already lost one child. She's 32 years old now. We need to know, we need to spend a lot of time with her to talk about, are you taking medications? What are you taking? Are you monitoring your sugar? So this is a very common scenario with this vulnerable population. So let's talk about what pregestational diabetes is. So Adriana initially had no diabetes, and then she developed gestational. With her third pregnancy now, she is considered a pre-gestational diabetic because she already has diabetes before the pregnancy. So this is another way of saying type 1 or type 2 diabetes, okay? So hyperglycemia during pregnancy and insulin resistance really places a lot of strain on the metabolic system and the heart and the kidneys during pregnancy. Okay, so it is really good if we can get a type 2 diabetic that wants to have a baby into some preconception counseling so we can get her glucose levels down to normal before she gets pregnant, control her weight, and just, get some good counseling on nutrition. Okay, so the diabetogenic state of pregnancy means that it usually begins week 20, whether the client is a diabetic or not. At week 20 of the pregnancy, beginning around then, insulin is resisted by the cells. So that's why it's called diabetogenic. It's causing diabetes. Insulin resistance means that the cells need more insulin in order to open them to allow the glucose to come in. So we have to sometimes give medication. If gestational diabetes begins, we might have to give medication like we did with Adriana, or with someone with pre-gestational diabetes, we might have to increase what medications they are taking, such as insulin. Okay, so those are some adaptations we have to do in pregnancy. And I'll talk about that again in a minute. Okay, so remember, the difference between diabetes and gestational diabetes is diabetes is an A1C of 6.5. It's an average of glucose on the hemoglobin of the red blood cells, okay? So if ever an A1C reaches 6.5, that's how we diagnose diabetes. So that could be type 1 or type 2. Now, you don't really need to know the difference between type 1 or type 2, but type 1 is an insulin deficiency, period. The pancreas does not provide, the beta cells of the pancreas does not provide insulin. Okay, so we have to give insulin to these people. It's the only thing that works. Whereas a type 2 diabetic usually occurs later in life. Obesity is the #1 cause of diabetes, family history, race. And it's type 2 diabetes is also known as insulin resistance diabetes or carbohydrate intolerance. In other words, sugars, even if they're complex, are not tolerated well without extra insulin or medications to enhance insulin and other effects, okay? So gestational diabetes is a woman that is healthy, and then after week 20, she develops diabetes. So she develops hyperglycemia during her pregnancy. Once that pregnancy is over, she has normal glucose, okay? That's why it's called just gestational. Sometimes that's a really hard concept for people to understand. So what is the problem with diabetes? Well, it's the hyperglycemia, okay? It's high levels of glucose in the blood. So anytime for an adult, okay, a fasting plasma glucose, in other words, you haven't had anything to eat for 12 hours. If it's over 100 or 125, okay, you're considered a pre-diabetic in some situations. So it's too much sugar, okay? If it's greater than 180 2 hours after a meal, that's diagnostic for hyperglycemia. Any glucose, any time of the day where you've eaten or not, if it's greater than 200 milligrams per deciliter, that's considered hyperglycemia, okay? And I'm going to use the word hyperglycemia instead of diabetes. It's because it's the physiological mechanism, okay? So when we think of hyperglycemia, now put aside gestational and type 2 and type 1 and all that. So hyperglycemia in pregnancy, okay? We don't want it, okay? It's too much of a problem, okay? Too much damage and too many risks, okay? So because it's during pregnancy, a woman is more prone to metabolic acidosis or diabetic ketoacidosis, okay? So we have to be much more strict with glucose levels, and we have to monitor them very closely, okay? So which lab assessment does the nurse know to be more accurate and effective for a pregnant client to monitor glucose levels? It's not A1C. A1C is a history. It's a great lab to draw in the chronic world and the non-pregnant world for an adult to get an idea of what's been going on with their sugar levels over like a 3-month period, okay? But it's not effective. It's not accurate during pregnancy. Remember, we've got the physiological anemia going on, the dilution of red blood cells. So it's not going to be accurate. So a better way to monitor blood glucose during pregnancy is to do finger sticks or draw blood, because we know what the glucose level is at that moment, okay? So we teach our clients how to stick their fingers, when to do it, and I'll talk about that in a minute, but keeping a log, there's a lot of education that goes on with our diabetic or our hyperglycemic patient clients. Okay, so let's talk again about the insulin needs in pregnancy. Okay, so we've talked about the diabetogenic effect. In other words, around week 20, you see in this chart, this graph, you might say, that the level of need of insulin begins to climb after week 20. And this is what we mean. It's like an insulin resistance occurring. And it goes all the way up to the end of pregnancy. We need more and more insulin or some kind of medication to allow the glucose into the cell. Okay. If a client doesn't get enough insulin, they become hyperglycemic. Their cells are actually starving, and they are starving. Even though they might be overweight, they're starving. And that turns into burning ketones instead, ketones. So we need more insulin, okay? Once the pregnancy is over, it drops, okay? So the resistance drops. And then especially if breastfeeding, you know, the resistance is lower. Breastfeeding helps to control glucose after a woman has a baby. Okay, so let's think about our overall care plan for our client with hyperglycemia. Now that you understand the pathophysiology, so education, client education, they need to understand and know the signs of hypo and hyperglycemia. So you can look in your text on page 244. There's a table 11.2, that has all the signs of hypoglycemia and hyperglycemia. So you need to know those, but you need to teach your client so they know that if their level of sugar is getting too high, their glucose is getting too high, especially during pregnancy, you know, 200 milligrams, they need to go to the emergency room. So we need to teach them. They're going to be dry. They're going to have a very thick tongue, dry, flushed skin, nausea and vomiting, cool, small respirations, deep, because they're becoming acidotic. So they need to go to the ER. And we need to teach them what are the targets for their glucose. So before breakfast, we don't ever want it to drop below 60, ever. And then 95. So before they eat, when they get up in the morning, they need to check their sugar, eat their breakfast, and then an hour later, check their sugar again to get an idea. Now, they might not always have to do it an hour, but at least do the 2-hour mark, okay? So before breakfast, 60 to 95. Before lunch, 60 to 105. 1 hour after a meal, less than 140, okay? 2 hours after a meal, it needs to be less than 120, okay? So that's what we have to teach, reinforce, remind, and explain to our clients. So we're going to support our clients. We're going to have them come to the office more often. We want to see how they're doing. We want to see their glucose log. And I always show them how to make a hard copy, because we want them to write down what their fasting level is before breakfast. What did they eat for breakfast? What was their glucose 2 hours after they ate? What was their glucose before they had lunch? What was it 2 hours after they had lunch? What was it before dinner? What was it 2 hours after dinner? Or and then check before they go to bed. We also reinforced a high protein, maybe with like turkey and cheese or chicken and cheese for a mid or night snack before they go to bed, because we don't want their sugar to drop below 60 during the night, okay? So we have to really, and then when they come back and we look at their log again, we can see patterns, okay? If their blood glucose after lunch really skyrocketed, well, what did you eat? So this is a really good way to guide what they're eating, the amount they're eating, and make some suggestions. And of course, these are also clients. If they're a type 1, they might benefit from a dietary consult, okay? So we also want to consider not only their hyperglycemia, but we need a specialist, okay? So a regular OBGYN provider can do a lot, but sometimes we need the specialist to help us manage a client like this. So maternal fetal medicine groups and regular OBs, they co-manage the client. They're more equipped for high risk situations. Their equipment is designed accordingly, and they tend to specialize in certain areas. Okay, and I worked next to a maternal fetus and medicine group, and I learned a lot from them, but they helped with glucose monitors or glucose pumps, doing other kinds of tests, measuring a more detailed ultrasounds and things like that. So fetal surveillance is done, with a high risk or by the OB, and what we're watching for in our fetus. We're watching mother's glucose, but we're also watching for the fetus because we want to see normal growth and development. Okay, so 20 weeks, every client gets an anatomical ultrasound. So it's just a gross ultrasound. We're looking for all parts. Okay, and for a diabetic, then about not before week 32, we'll do a fetal echocardiogram via ultrasound, of course. So we do the ultrasound and we do an echo on the heart through that ultrasound. And it just kind of gives us an idea how the heart is functioning. Sometimes we can see any malformations, but not always. So we're looking at that. And then we're looking at growth, the amniotic fluid volume, with hyperglycemia, that amniotic fluid volume climbs. So we need to look at that. And we need to look at the BPP itself is a biophysical profile, and it's particular. We're looking for 4 parameters, and we give 2 points for each. And so the BPP is telling us the well-being of the baby. So is the baby moving? Does the baby have good reflex activity? Is the baby practice breathing? How much amniotic fluid? So that's kind of a shortened version of a BPP. And then we also might do a non-stress test, because what we want to do is we want to look and put a monitor on mom that shows the fetal heart rate pattern, and she has a button. Anytime she feels that baby move, she pushes the button. And at that point, we want to see that fetal heart rate go up. In other words, movement increases demand on the fetal heart and demand for oxygen. So if the heart rate goes up, that means they're able to respond to that need. If it goes down, then we know something's going on with the placenta. The baby's not getting the blood flow that it needs. Okay, so we can do that every 3 weeks. We can do a BPP ultrasound. Actually, we do an ultrasound for growth every 3 weeks. We can do BPPs in regular ultrasounds anytime. Okay, so we do that every couple weeks during their late second to third through the third trimester, just to keep an eye on the baby. If our hyperglycemic client has a very large baby, or if there's some concern about well-being, we also might do a contraction stress test. And so the difference between that and the non-stress is that we're causing contractions. So we're bringing contractions into the picture. And we want to see the fetal response, the fetal heart response to those contractions. Are they climbing? Are they maintaining? And they're not having any late decelerations. So we're going to do that. And that way we know the baby mom could probably go into a normal vaginal delivery. Okay. So our plan for labor is an expectant approach, especially for a hyperglycemic client who's not in control, has a large baby, lots of fluid, and the risk associated with that. So expectant means we know how to anticipate the risk. Okay, we know what the risks are, so we can plan accordingly. If her baby is macrosomic, if that baby's at that 90th percentile of growth, we might have trouble with a vaginal delivery. There might be some labor dystocia, shoulder dystocia. Babies of diabetic mothers are big. They have a broader chest. It's not just size, it's their structure. Their chest is more broad. Okay, shoulder dystocia. Okay, so we might have to end up doing an emergency C-section if we have trouble, if we can't, if we're not successful in a vaginal delivery. So we take that expectant approach. We also have to think about stress on the fetus, meconium stains, or meconium being passed before delivery. So that's a whole nother, a different pathway. We have to worry about injury to birth, infections, injury to mother. Okay, so we have to kind of go step by step and make those plans. And then the postpartum period, hyperglycemia during pregnancy. So I have taught you that if the mother is hyperglycemic during pregnancy, so is a fetus. And that's why all the extra fluid volume, amniotic fluid volume. So the baby is used to hyperglycemia, just like a diabetic is used to hyperglycemia if they're not controlled. The minute the available glucose to their body is reduced, they become hypoglycemic very quickly. So we, once again, do the expectant approach for a newborn. We know that newborn is going to have hypoglycemia early. So we promote breastfeeding ASAP, or at least within the first hour or two after delivery, to help that fetus, give that fetus some nutrition, or that new baby some nutrition. So we promote breastfeeding. Breastfeeding, according to the evidence, a mother that's a diabetic and has a newborn, breastfeeding reduces that newborn's risk for developing diabetes later in life, believe it or not. So we promote breastfeeding because of the immunoglobulins, which we talk about when we talk about the newborn, and there's just so many other advantages. So during postpartum, skin to skin breastfeeding, monitoring mother, teaching her about breastfeeding, teaching her about how to look for signs for hypoglycemia in her baby and herself, because her needs now have dropped as well. So insulin levels drop after delivery. So the insulin resistance isn't as bad. So we have to adjust our glucose. So during labor, we're not only monitoring baby and keeping an eye on the fetal heart pattern, we're also monitoring mother's blood glucose every hour. So we're going to have available IV, both dextrose and insulin, and we have to kind of titrate it throughout the labor. And then post delivery, then we know we have to watch it carefully until it goes back to what it's expected. So we adjust accordingly. Okay, so there's a lot of teaching for a diabetic. Okay, so this is usually on a high risk OB floor. Okay, so other things we need to talk about, and we can talk about them during the pregnancy, is also postpartum. What do we want to do for birth control? Now, you haven't learned about birth control yet, but I want to explain that a diabetic is at risk for blood clots. That's another risk a diabetic is facing. So we have to make sure our client understands that. So we don't want to give her any estrogen-based contraceptives. We're going to give her progestin only. Okay, so there's several options we have there that we can give her. So we need to get her started really soon, because we know that breastfeeding is not an effective contraceptive, and mom needs to know that. I've had diabetics return to me pregnant at 6 weeks. Not good, especially if they had a C-section. Oh my gosh. Okay, so maternal effects of hyperglycemia. So let's kind of look at this a little more, okay? For the diabetic client or the client with hyperglycemia, short term, she can go into ketoacidosis, okay? Polyhydramnios, we talked about. She's at risk for preeclampsia, her placenta pulling away from the uterine wall with massive bleeding, blood loss and loss of life for her and her baby. She's at risk for high blood pressure. She's at risk for labor dystocia, birth injuries, lacerations, cervical lacerations, postpartum hemorrhage, and infections. Okay, blood clots. I don't have blood clots in there. I need to add that. And then long-term, effects of hyperglycemia. So this is for her and any diabetic. I just wanted you to know this because I know MedSearch 2 teaches this, but just so you know that hyperglycemia is very destructive to vessels, blood vessels. So initially microvascular, in other words, around the eyes, in the kidneys, and in the nerves of the periphery. And that's why an early diabetic can even feel have to have their eyes treated because they develop blood clots in the little vessels of their eyes that have to be lasered. And then the kidneys are easily destroyed or at least damaged by diabetes. And then the neuropathy. Long-term, the brain, the bigger vessels, the heart, and then the extremities. So I'm going to add blood clots in here. So that means any kind. It can be superficial, it could be pulmonary embolus, it could be deep vein thrombosis. Okay, so here's just a depiction of what how ketoacidosis, the pathway it follows. So hyperglycemia increases osmolality. In other words, that's kind of hard to explain. It's thicker, I can put it that way, but the cells begin to dehydrate, okay? And there's an osmotic diuresis. Extracellular fluid volume drops down, okay? Decreased glomerular, so that's the kidneys. They can go into shock, okay? Glucose in the urine and acidosis, azotemia, the BUN goes up. Electrolyte loss. So this is a very severe situation, and certainly that's why we want to promote education. You know, don't let your blood sugar get so high. So what are fetal effects of hyperglycemia, early versus late? So early, if a client comes in early in her pregnancy and her sugar has not been controlled, and I'll give you a number of 8 to 9 A1C prior to pregnancy, and she gets pregnant, that baby's going to have congenital disorders, cardiac, limb deformities. She could have a spontaneous abortion. Most of the women in the OB population that we treat for hyperglycemia are not type 1 or type 2 diabetics. They are gestational. And the reason that is because most type 1 and type 2, I don't want to say most, but many type 1 and type 2 can't carry a baby very long if they're experiencing too much hyperglycemia, because they'll have a spontaneous abortion. Okay. And then, so that's early. So as the pregnancy progresses, later into the pregnancy, remember, baby is growing large, macrosomia, 4,500 gram baby, or above the 90th percentile, polyhydramnios, extreme prematurity. Now, a baby can be born extremely premature and yet not have low birth weight. And so this would be a diabetic baby, okay? Polyhydramnios, birth injuries, hypoglycemia, postpartum, respiratory distress for the newborn. Respiratory distress because insulin inhibits the production of surfactant, so that there's a respiratory factor in it. I did also want to go back and tell you, I forgot, there's one more thing here. What was I thinking? With injury, oh, I don't remember what it was. Okay. Oh, I know what it was. Oh, I got it in there. Postpartum hemorrhage. I just want to make sure I got it in there. Okay. Okay, so let's be done with that. If you have any questions about that, you can send me an email, or you can send me a text, or you can let your instructor know. You'll have this PowerPoint slide as well to go with the recording, so you can look this up in your text or look through my other PowerPoints, okay? So substance use disorder in pregnancy. So substances, we're talking about food, nicotine, alcohol of any kind. So beer, wine, spirits, whatever you want to call it, they're all alcohol, right? Some have a higher percentage, but they are all alcohol. So if they're consuming them during the pregnancy, they're at risk for a lot of things. Okay, so let's talk about this substance use disorder in pregnancy. So pills as well, of course, drugs. So ideally, there are rehab programs for pregnant women. In other words, let's refer our client who has a drug use disorder and she's pregnant now. Let's get her into a rehab program, and we can do it outpatient where she visits every week. And let's get her on a agonist-antagonist drug like Subutex, the best on the market for pregnant women. It's the safest for pregnant women, and I'll explain that to you. So if we do that, then she's going to learn and she's going to feel so much support. She's going to take ownership, hopefully, of her pregnancy, and she's not going to suffer with the guilt of pregnancy, of a baby with withdrawal symptoms, because we're going to help prevent them. Okay, substance use disorder during pregnancy and the postpartum period. So methadone is an agonist opioid, okay? It's not as potent, and I've got another slide to show you about methadone, but it's more safe than any other opioid that a client wants to take if she wants to go through rehab and weaning and getting off the medication. So we can allow methadone, but it's better for Subutex. Now this slide says Suboxone because it's Subutex with Narcan in it. We really don't want to give Narcan ideally to a pregnant woman. I'm sure there are some places that do that, but ideally it's best just to use the buprenorphine itself, okay? So if our client is in a rehab program, if she's compliant with the program and she's not using any other drugs or alcohol, and she's going to the outpatient center and compliant, we want her to breastfeed. There's only a small amount of methadone or Subutex in breast milk. Okay, so this is an opportunity for her to feel successful again, because she can breastfeed her baby. And that there's a lot of pride in a mother who can breastfeed, and baby and mom are weaning together. So there's fewer episodes of withdrawal symptoms, especially with the Subutex. Actually, it's buprenorphine is the generic name, and I should be putting that in here. Buprenorphine. Oops, too many P's. Okay. Okay. So we also want to promote, she's successful. Let's promote smoking if she's been smoking. Let's promote smoking cessation. Let's promote abstinence from alcohol for the rest of her life. So you're doing a real service for her. Every success she feels is going to give her more strength and confidence to overcome other things. So the opioids come in as agonist, antagonist, or partial agonist, okay? So opioids like heroin, oxycodone, hydrocodone, fentanyl, all those opioids, okay? They have an effect on a person, and they hit all the receptors, the endorphins, and cause euphoria, pain. It's just some people really are attracted to these drugs for some reason, but they can develop a dependence upon them. In other words, they're taking them, and then if they don't take them, they begin to have side effects, okay? So, but both methadone and buprenorphine are safe during pregnancy if they're controlled, and during breastfeeding, okay? Methadone and buprenorphine are different than the other opioids because they don't produce that heroin rush feeling. That they satisfy the body for cravings for opioids, but they don't get that high, okay? Buprenorphine is safer because it's only a partial opioid agonist, so they don't they get less effect than methadone, and they tend not to develop a dependency on it, at least a physiological dependency on it. They might be addicted psychologically, okay? So, but buprenorphine is best. So if we do mix the naloxone with it to make it Suboxone, then it helps reduce that dependency risk even more. But we tend not to do that during pregnancy. We can do that during breastfeeding, but not pregnancy. Okay, so those are excellent things to talk about. So the last thing I want to talk to you about are mood changes during pregnancy. And this is dependent a lot on, of course, family history, past history of depression, family stress, economic stress, for all kinds of things, okay? Some women just experience like a postpartum blues right after delivery of their baby, and it might last 2 or 3 days, or 7 or 8 days, maybe up to 2 weeks. Okay, it's just a transient period, emotional, very vulnerable to moodiness. It's just, some of it is associated with the hormone changes and just the change in life. It's a big thing, okay? But if those blues continue, they're persistent, they last longer than 2 weeks, well, it's more like a depression. So in other words, she's not coping very well. You know, her hormones are normalizing, and she should be able to cope and adjust. But if not, we're more concerned about a longer term depression. So she might lose interest in taking care of her newborn, might not be bonding well with the baby. She might not be taking care of herself. She's losing interest in things that she normally enjoys. She might become suicidal, infanticidal, or homicidal if it becomes a very deep depression. But that's not the same thing as psychosis. Psychosis is totally independent from the other two. Psychosis we see in women with a history of bipolar, or maybe schizophrenia, or bipolar 1 or 2, or some other mental disease or disorder. It's independent of the blues or depression, okay? Time is not a factor. So it can occur anytime, okay? It can occur during the pregnancy, but we usually see it postpartum. I had a client who had a history of bipolar, and I knew that, and she was on medication, and then she got pregnant. She stopped taking her medication. When she came to see me, and she told me her history, and we talked about it, and I said, great if you're functioning well without your medications, but I am concerned because when you get closer to delivery, you know, all the different hormonal changes, it might be, we might consider later starting you on something that's, I know will be safe for the baby, that will kind of help you adjust. She said, no, I'm okay. But a week after she had her baby, she had a psychotic. She had to be hospitalized, and she was in for like a week, and then she got back on her medications, and but she didn't have to suffer. I really wish she had really started something. But so psychosis can start at any time. Bizarre, impulsive hallucinations, delusions, okay? History, I told you about. And they also, of course, could become suicidal, infanticidal, or homicidal. You don't have to be psychotic to become suicidal, okay? So I just wanted you to understand that. Sometimes students get that mixed up. Okay, so if you need help with any of this, just let me know. Thank you.